Without going into much detail, I will invite Dr. Parul CHAWLA Gupta. She will be speaking on basic steps of pediatric cataract surgery for a novice pediatric surgeon.
Good morning to all. Thank you, sir, for the introduction. So today I'll be discussing the basic steps of pediatric cataract surgery for a novice pediatric surgeon. So congenital cataract has a worldwide prevalence of 4.24 per 10,000 people, with the largest prevalence found in Asia. It is one of the most important causes of treatable causes of childhood blindness. So what should be the timing of cataract surgery in children? To prevent stimulus deprivation and myopia, dense, visually significant bilateral congenital cataracts, surgery should be done around 6 to 8 weeks of age. And in unilateral visually significant cataract, it should be done around 4 to 6 weeks of age. There are increased rates of postoperative glaucoma in the first 4 weeks of life. That is why we don't do pediatric cataract surgery too soon. So the incision should be essentially a superior clear corneal triplanar incision. 2.2 mm or 2.8 mm is preferred superiorly because the wound is protected by the upper eyelid from trauma. Scleral incisions 2 mm from the limbus can also be done using conjunctival peritomy, but they are used when usually we do a rigid PMMA IOL. Smaller, tighter fitting incisions help in better maintenance and stability of the anterior chamber, and we should always minimize times in and out of the eye. And side port incisions of around 1 mm, uniplanar incisions should be given 180 degrees apart for better maneuverability. Sometimes children have small pupils. Less than 4 mm pupil leads to higher complications, and these small pupils can be due to posterior synechia due to uveitis, trauma, persistent fetal vasculature, or pupillary fibrosis. We can use pre-op dilators, or we can use intracameral preservative-free adrenaline, or we can also use intracameral mydriatic anesthetic drops, which are now easily available. The anterior capsular rhexis is difficult in children because it is thinner and elastic, it is convex shaped, it tears easily and runs peripherally. The AC is shallow and it is a small eye. The IOP is low and the sclera is less rigid and easily collapsible. And there might be poor red reflex due to the opacities. Anterior capsular rhexis can be done using many techniques like curvilinear capsulotomy, using a vitrector, using a 2-incision push-pull technique, or using the femtosecond laser, or using the plasma blade, or the Zepto. We should always stain with trypan blue dye, that is 0.06%. It makes the capsule rigid and stiff. We can do the CCC manually with the cystitome and then follow it up with the Utrata forceps. We should always make a CCC which is smaller than the IOL optic diameter, and the anterior CCC should be around 5 mm and the posterior around 4 mm. Vitrectorexis can be done. This can be used for fibrotic capsules. So what are the tips for anterior capsular rhexis? We should always pull centrally, use a cohesive viscoelastic, and take frequent bites of the anterior capsule. A cohesive viscoelastic, it flattens the anterior capsule in children, it keeps the anterior capsule taut and counters the effect of low scleral rigidity and vitreous upthrust. Multi-quadrant hydroresection should be done using a cannula mounted on a 2 cc syringe. At least 3-quadrant dissection should be done to facilitate easily lens matter being aspirated. So coaxial and bimanual irrigation and aspiration handpieces should be used, and we should start from periphery and swipe clean. IOL implantation can be done using the high viscosity viscoelastic. Push the leading haptic underneath the capsule and then push the trailing haptic. A single piece hydrophobic acrylic IOL is preferred within the bag placement. It leads to less PCO and pigmentary deposits. And 3-piece IOL can be placed in case of an advertent posterior capsular rupture or if the patient is not affording. Monofocal IOL is usually preferred in children. Multifocal can be used in children more than 5 years of age with bilateral cataract. Lens material ideally should be a hydrophobic acrylic material, and peripheral iridectomy can be done in cases of aphakics if we are leaving the patient aphakic, or if the patient has uveitis or any traumatic cataracts. It can be done using a vitrector, and if it bleeds, we can tamponade it with air or viscoelastic and put intracameral ADR. Primary posterior capsulotomy and anterior vitrectomy should be done, as PCO is the most frequent complication in children, around 100%. It should be done in the cut IA mode, that is a cut irrigation aspiration mode, and it is done in patients less than 8 years old, mentally retarded children, or those having nystagmus. It should be always made smaller than the anterior capsular axis. And suturing should be done at least in children less than 2 years of age, because of the low scleral rigidity and increased elasticity and more vitreous upthrust in children. And they can be sutured, the ports can be sutured with 10 or nylon or Vicryl. For children greater than 2 years of age, we can do a sutureless technique with proper wound hydration. It decreases the surgical time and avoids suture related problems. We should always use a preservative free moxifloxacin at the end of the surgery and give intracameral steroids or subconjunctival steroids. And we follow the patients up subsequently, keeping them on steroids and antibiotic drops, and amblyopia management must be done after that. So I'll be showing a few videos. Sound please. Sound. So this was a patient of a lamellar cataract, pediatric patient. We made the side ports. We stained the capsule with trypan blue dye. Then we injected the high viscosity cohesive viscoelastic and made the main port. Then we started the capsular axis with a cystotome and completed it with a Utratas forceps. Multi-quadrant hydrodissection was done, and bimanual irrigation aspiration followed it up. Then the bag was distended with viscoelastic and a 3-piece hydrophobic acrylic IOL was placed in the bag. It was dialed in position using the Y, and then subsequently the posterior capsulotomy was done using a vitrector. The side ports and the main port were sutured. This is a video showing use of intracameral mydriatics in pediatric cataract surgery. We stained the capsule. It was small. We inserted the intracameral mydriatic and see how beautifully the pupil has dilated. Then we injected the viscoelastic and made the main port. Frequent bites of the anterior capsule were taken, and the capsular axis was completed under viscoelastic. Again, a 3-piece hydrophobic acrylic IOL was implanted. Sometimes implantation and dialing can be difficult, so we need to depress the IOL and then dial it into position. The cut IA mode was used, and the wounds were hydrated because it was a bigger child. This video shows use of intracameral triamcinolone in pediatric cataract surgery. In this, mydriatics were not used, just the visco-mydriasis was used. We dilated the pupil with the viscoelastic. Another important tip is that polishing, IOL capsular polishing should be done very nicely in children. It can decrease the rates of PCO. In this, we implanted the single-piece hydrophobic acrylic IOL and then did the anterior capsulotomy and vitrectomy. We injected Canacort and washed it off partially with the viscoelastic, with the intracameral moxifloxacin. This video shows rexes with a vitrector because the anterior capsule was very fibrotic. So the cut IA mode of the vitrector was used. This was a partially absorbed cataract. Since the eye was small, we decided to leave the patient a phakic and did a peripheral iridectomy, which is a must in phakics. So to summarize, congenital cataract is an important treatable cause of childhood blindness, and it should be managed promptly to achieve good visual acuity. In the back placement, along with primary posterior capsulotomy and anterior vitrectomy, is essential in the younger age group, and post-operative care and follow-up are inevitable to achieve an optimal outcome. Thank you so
Thank you,
much.
Dr. Parul, for the nice presentation. Any question from the audience? Although we will take after each of the presentation